Hello, everybody, and welcome to one of our Friday recordings for Thursday Night Lives. Today we have Dr. Michael Hutz with us. He's an assistant professor of Head and Sleep Surgery Department of Otolaryngology, but he is going to introduce himself to you guys.
All right. Well, Renata, thank you so much for having me. Happy to be a part of the webinar. So as Renata said, my name's Mike Hutz. I'm the chief of sleep surgery at Rush University Medical Center in Chicago. My background is I'm an ENT by training. So I trained at Loyola University Chicago and then ended up doing a sleep medicine and surgery hybrid fellowship at the University of Pennsylvania with Raj Dadia. And then through Raj, I got to work with Mariana Evans. And that was kind of my first exposure to palate expansion, and Raj trained me in kind of this version of surgically assisted palate expansion we'll talk about, and kind of the benefits of MMA and skeletal surgery on the airway. So my whole practice is basically airway and sleep apnea, and it ranges the spectrum from nasal surgeries to optimize nasal breathing, improve CPAP compliance, to soft tissue surgeries. Some people still will benefit from pharyngoplasty and tonsillectomy, to things like hypoglossal nerve stimulator implantation. In the right patient, something like the Inspire device can be effective. And then things like skeletal surgery. So palate expansion, maxillomandibular advancement, genioglossus advancement. And that's kind of the skeletal aspects of things is really where, my passions come in and where my kind of career is focusing. So, what I want to talk to you today is, I was just trying to find some form of witty title for you guys. So the talk is called From a Studio Apartment to a Comfortable Home. And so I'm going to talk about how maxillary expansion, widening the upper jaw, how that can potentially impact the airway and sleep apnea.
Yay, we're so excited about this. I mean, it's one thing to have an orthodontist come talk about palatal expansion, but whenever you have a sleep surgeon, usually our encounter with sleep surgeons that are not in this field are usually just, cutting uvulus out and immediately going to surgery. So this is super exciting for us to hear from you, your perspective, since you know both worlds. And I mean, working with Mariana Evans, that is just incredible. So we're so happy to have you today. And welcome to our members. You guys are welcome to ask any questions. We're going to leave the questions for the end, but we are excited for your presentation. Thank you for being here.
Thank you. And, Renata, I would love it for this to be, as much a conversation as a presentation. So, if I'm going through things and questions come up from you, don't hesitate to ask about certain things, but otherwise we'll dive right in.
Perfect.
So my disclosures don't apply to this talk, but I am a consultant and on the advisory board for the Inspire medical team and some kind of neural stimulation companies. So the overview is we're going to talk a little bit about the evolutionary changes of the facial skeleton and why, palate expansion is, maybe not just coming in vogue, but we're seeing it more and more as a necessity for certain patients. We'll talk a little bit about rapid maxillary expansion in kids. I'll start by saying I'm not, I treat predominantly adult obstructive sleep apnea and adults. So I'm certainly not as much of an expert as probably some of the other folks that have come in from the kid side of things. But then we'll talk a little bit about the indications you think about for when this would be useful in adults. We'll talk about kind of surgically assisted maxillary expansion, some non-surgical expansion, and then kind of bring it all together at the end. So, with the wide variety of speakers that have come through here, I'm sure you have heard this from a lot of different perspectives. But, interestingly, there was no significant evidence of malocclusion as a human trait prior to the Industrial Revolution. And, working with Mariana Evans, her team, Dr. Reem Abdul Rahman, and then a pediatric dentist from Chicago, Kevin Boyd, worked by looking at some of these child and adult specimens from the Penn Museum called the Crania Collection. And they were able to compare, basically CT scans of these pre-industrial children and adult skulls with kind of more modern skulls. And, some of their preliminary data, and maybe this has been advanced, in more recent years, but it was essentially that the malocclusion traits were most markedly seen in an AP, or an anterior posterior front to back dimension of the upper and lower jaws, and that the retrognathic or underdeveloped mandible or lower jaw was kind of more common in industrialized cultures and much more rare in non-industrialized cultures. And so there's this whole emerging discipline of evolutionary medicine, which I think is just fascinating as to why are we seeing certain traits in humans today that are likely not beneficial, but seem to be kind of coming through and perpetrating. So, this is just some of the examples from Mariana, where she shows kind of the pre-industrial skull. Let me see if I can change this to laser pointer. So this is the pre-industrial skull on this side versus kind of a modern day composite. And you can see that these pre-industrial skulls are much broader jaws, their midface, their orbital rims, their maxilla, their mandibles, everything is much more, wider and more prominent than kind of the modern day skull with this constricted maxilla and kind of underdevelopment here. This is just another shot. So this is looking at an axial view, axial plane, where it's kind of a cut straight through, and it's showing kind of the palatal area. So this is the area of the hard palate here versus the kind of narrow palate of the modern day skull. So pre and post, you can see a pretty significant change in the volume there, or area. And then on these ones, you see, perfectly straight uprighted teeth. You see this broad palate versus kind of this narrow, higher arch palate. Now, obviously, we're not going to see a bunch of mucosal inflammation on a 400-year-old skull. But here you can see into the sinuses, where the sinuses are a little bit smaller. There's congestion. The turbinates are swollen. And you see these upper teeth are what we say buccally flared. So they're kind of tipped outwards. And you see this narrow upper palate. So what has changed? So, one of my colleagues from Penn, Jason Yu, who's now a sleep surgeon down at Emory, worked with a couple of my colleagues, Raj, Mariana Evans, and did a really, really extensive, what's called a scoping review. So it's not a systematic review, but a scoping review is basically, let's look at all of the information that's ever been published on kind of craniofacial maldevelopment as it relates to sleep apnea. And so they kind of scanned 18,000 articles, and 260 were eventually fully reviewed, 163 included. And they looked at things like secular change, so change over time in certain populations, over generations. They looked at how diet is impacting craniofacial development, breastfeeding or non-nutritive sucking habits like pacifier, nasal obstruction or mouth breathing, and how that relates, and masticatory or chewing muscle function. And so this was just a systematic review of 27,000 infants, looking at the impact of how breastfeeding or non-breastfeeding may impact things. And what they found in this group, at least, was that 6 months of breastfeeding was protective against crossbite and malocclusion. Exclusive breastfeeding was better than partial or part bottle, part breast. And that at 12 months of breastfeeding, there were lower odds of malocclusion. So again, this doesn't mean that if you only breastfeed your kid, their teeth are going to be perfect for the rest of their life, but this is kind of one data point. And one of the theories is that essentially the way a baby latches to a breast kind of promotes maxillary and mandibular growth versus a pacifier. The way they suck on a pacifier, in German, we used to joke and call it Schnulli mouth, Schnulli pacifier, where you would get kind of this narrow, high arch palate and kind of crowding of the teeth when kids or babies would use a pacifier for a long time. The other thing, another one would be diet. So there's been a number of animal studies that essentially, in some of these, they took, either monkeys or rats, and essentially, very early in life, gave some their normal diet and then some essentially mush, water, mushy food. And what they found was that very quickly, the jaws of these animals essentially became, dental crowding, narrow arch, retrognathia, underdevelopment. Some of these monkeys started kind of chronically mouth breathing as opposed to nasal breathing. And then once they reintroduced a hard diet back to these animals, a lot of them were able to kind of transition back, if they did it soon enough, to kind of normal jaw growth. There's been, epidemiologic studies looking at global populations, looking at, in the same country, rural youth versus urban in the city. And what they found was that there was a lot more issues with occlusion and dental crowding in these urban youth. And, some of the thoughts are that those kids are exposed to a lot more processed and soft foods growing up rather than kind of more, staple farm diet, other things like that, where maybe you have to chew and use the jaws more when you're growing. And so again, similar to pre-industrial skulls from Finland and England, showing normal occlusion kind of pre-industrial versus, significant rates of occlusion, malocclusion post-industrial revolution. Other things we think about, so, especially with air pollution, all these different things, we're seeing a lot more allergies in our kids. And so chronic allergies, chronic mouth breathing, nasal obstruction, and some of the characteristic things we see are, adenoid facies is what we call it in ENT, where you have increased palatal height, a narrow upper jaw, higher rates of crossbite, a lot of kind of crowding or crooked teeth, underdevelopment of the jaws. And so the jaws kind of grow long and narrow versus wide and forward. And we think that, this aberrant breathing is potentially contributing to it. Now, one of the things we don't know is, is this the chicken or the egg? Are they already having other issues causing their underdevelopment of the facial growth, which then leads to more nasal obstruction, or is it the nasal obstruction? So, we probably, they may in fact play kind of hand in hand. So, we talk about malocclusion and crossbite and dental crowding and all these things. So who actually cares? Well, a lot of lay people are caring a lot more now. And this guy, James Nestor, most of you are probably familiar with his book, Breath. That was a New York Times bestseller that came out in 2020. And, that kind of refocused a lot of people on like, oh, we've forgotten how to breathe. People don't breathe through their nose anymore. Here's, some of the things in terms of mouth breathing. And granted, there's some investigative, journalistic liberties taken. So it's not all completely hard science, but certainly it's piqued a lot of people's interest in this. And then, the pandemic really drove a lot of patients to realize when they have to wear a mask all the time, they're like, I can't breathe through my nose at all. And so a lot of people that never realized they had a problem realized how little they could breathe through their nose, which drove a lot of people to like ENT clinics, for instance, to say, hey, I can't breathe through my nose. Can you try to fix that? So, what's the traditional ways to treat nasal obstruction? And the typical ENT training and the way I was trained and the traditional approach is things like topical steroids. So we think about Flonase, we think about topical antihistamines like azolastine. Saline irrigations or saltwater rinses in the nose are, one of the healthiest things we can do. And there's actually been pretty good evidence that those can help improve kind of mucosal function in the nose and mucociliary function, or the little nasal hairs that help regulate mucus through the nose. We think about things like they have a deviated septum. Let's do a septoplasty. Let's reduce the turbinates. They have, weak nasal valves or sidewalls. Let's consider some type of nasal valve repair surgery, functional endoscopic sinus surgery. But the big thing that I've realized that once you see it, you can't really unsee is that what happens if the room is too small? So these patients have nasal congestion, they can't breathe. You look in their nose and basically there's a bunch of crowding. But in reality, maybe the issue is that you look in their mouth and they have a really narrow palate. They have a lot of dental crowding. And so the entire midface is essentially underdeveloped. And so, this is where the title of the talk comes from. No matter how much you rearrange the furniture in the room, you're still living in a studio. And that's kind of how I describe it to patients, that no matter what we do, yeah, maybe a nasal surgery can improve you 50%, but it's still a size problem. Other things, this is a paper that I published with Dr. Dadiat from Penn, and it was just looking at kind of in our OSA population, the impact of a narrow palate. And so what we found in our cohort of 93 patients was that people that had a narrower, high arch palate had higher rates of deviated septum as well. And so people that had a really broad maxilla, like on this left side, in general, this is not for everybody, but in general, trended towards having straighter septums. People with narrow, high arch palates had more of a deviated septum. And the thought is that during facial development, the septum is cartilage, the upper jaw is bone. And as the bone becomes higher arched, the cartilage is what's going to bend and move. And so you have kind of a set distance from the skull base to the upper jaw, and that just kind of, contracts and causes that deviation. So that's kind of the theory behind that. But the other thing is that this is a paper that Dr. Stanley Liu and his colleagues had put out a couple years back, where they looked retrospectively at a bunch of patients that had undergone various nasal surgeries, and they compared patients that had complete resolution or, based on their predetermined kind of standards of nasal obstruction versus persistent nasal obstruction postoperatively. And what they found was that people that had a narrow high arch palate were much more likely to have persistent nasal obstruction postoperatively. So it kind of lends to the same concept that I brought up before, that you can rearrange the furniture, but it's the room is still too small to begin with. So that's why we care about this stuff. So just really briefly, because I know you've had orthodontists and other people that are much smarter than me talk about this, but maxillary expansion in kids was first described back in 1860. This was not the expander used. That would be very impressive if it was. But basically the concept is, typically anchored on the teeth. Expansion screw is turned, daily or whatever, a couple times a day, depending on the orthodontist. You rapidly expand over a period of several weeks. You keep the expander in for a couple months afterwards. And because kids' craniofacial structures are still so malleable, it's pretty easy to expand and kind of, it's not as soft as Play-Doh, but essentially you can kind of redevelop things pretty easily at that age. So indications, previously would be things like prepubertal patients. So the thought was that, around puberty is when the mid-palatal suture fuses more and more. And so these tooth-borne expanders may be, less effective. Patients that have crossbite, such as this picture down here, if they have a bunch of dental crowding, where there's basically just not enough space in the room, in the mouth for the teeth. Maybe it's a cleft lip or palate patient that has, partially collapsed maxilla or obstructive sleep apnea. And so when we think about, the impact of maxillary expansion in pediatric patients or kids, this was one study that Dr. Audrey Yoon had done with Dr. Liu and his colleagues, where they looked at 50 kids. Their nose scores significantly improved. Their nasal valve angles, or the inside of their nose, the degree, even though 2.5 degrees doesn't sound like a lot, it's actually a pretty substantial amount of improvement. And what they found was that essentially the wider the diastema, or the more space you were able to expand, the higher the change in nose score, the more nasal breathing improved. In terms of OSA, this was a study from 20 years ago already, but they had looked at 31 children, narrow maxilla, their BMI, they weren't super morbidly obese. They had persistent sleep apnea after they had their adenoids and tonsils removed. They did a palate expander in these patients, and on average, they went from an AHI of 12 to less than 1 in all 31 children. And in 12-year follow-up of the 23 that they were able to wrestle up, they basically had normal sleep studies. So again, I don't think that this is, we have to take all of these studies with small numbers a little bit with a grain of salt. But it shows, reasonable evidence that this could also be a pretty, reasonable option in a select subset of patients that have had their adenoids and tonsils removed. They still have sleep disordered breathing, and they have some of these craniofacial deficiencies. This was just a general systematic review of kids, different research studies looking at kids. And again, on average, AHI with palate expansion went from 9 to 2.7. So technically still moderate sleep apnea in kids, but pretty significant, reduction for just expanding the palate. And the oxygen nadir, the lowest oxygen level, was 96% from 87%. And so there was a pretty substantial reduction in sleep apnea, 73 to 95% in patients who had previously undergone adenotonsillectomy. Again, the caveat being, if a kid is morbidly obese or has other, sleep disorders or medical conditions, this is not going to be a one-size-fits-all, but definitely something to keep in mind. This is another study that Dr. Yoon had put out that was really interesting, and it was looking at, what is the impact of maxillary expansion on adenotonsillar hypertrophy. And so they had 60 patients. They basically had 20 in control, 40 patients in the expansion group. And they got kind of pre and 9 and 12 month post expansion CT scan or CBCT scans. And essentially what they found was that there was a pretty reasonable reduction in the size of both the adenoids and tonsils. So they didn't, resolve it completely, but the size of the tissue based on these scans was reduced. And so the thought is, if you're converting maybe these kids more to nasal breathing versus mouth breathing, perhaps the adenoids and tonsils are not kind of working in hyperdrive to filter, to basically work as the nose should be working. And so they become less hypertrophied. So again, theories: decreasing nasal resistance and improving nasal breathing. We think increasing the maxillary arch width can improve the tongue position. So if the tongue now has space in the mouth, you can have more proper lip seal, tongue position with the mouth closed. And then there's some thought that maybe it increases just the oropharyngeal space, so the space in the back of the oropharynx, and maybe that can also put some extra muscle tension on the lateral walls. So in terms of adults, the indications are not too dissimilar from the pediatric patients. So we think about dental or skeletal crossbites. So this is an example of a dental crossbite. So the molar here on the maxilla is inside the molar on the mandible, or skeletal crossbite, where this patient, on paper has a class 1 occlusion, but in reality, their maxilla is really narrow, which is why the teeth have been tipped out. We think about patients that are having a lot of nasal obstruction, where we've already kind of ruled out, some of the low-hanging fruit, like deviated septum or nasal polyps or other things like that. They have a narrow high arch palate, such as this image here. Limited intraoral volume. So some of these patients will come in and say, my tongue just feels like it's too big for my mouth. There's not enough space for it. And then patients with sleep apnea. So, the first kind of introduction, at least in my world, to palate expansion or surgically assisted was through Dr. Stanley Liu at Stanford. And he had introduced in 2017 the concept of DOME, or distraction osteogenesis maxillary expansion. And it essentially applies kind of a very, well-studied SARPI, or surgically assisted palate expansion, which has been done in oral surgery for, dental purposes or malocclusion purposes for many years, to the OSA population. And so the phenotype was this narrow high arch palate and nasal obstruction. And so this was kind of the more traditional MSE that was more commonly used at that time. And you see this patient that has a very narrow high arch palate, and then postoperatively has a very broad palate. The teeth are nice and uprighted in this picture. So this pilot study that was back in 2017 was 20 patients. It was typically people that were PAP intolerant or positive airway pressure, so they couldn't use CPAP. They had a narrow palate. They didn't have, big adenoids or tonsils. Malampati is, for those that aren't familiar, is basically where the mouth is open, you stick your tongue out, and how much of the back of the throat can you actually see? And what you saw was about a 50% reduction in the AHI just by expanding the maxilla. And something where you're not doing some kind of crazy invasive intervention is a pretty significant reduction. So, I don't promise patients that they're going to be cured from their sleep apnea, but in general, their nasal breathing significantly improves. The nose score is this nasal obstruction septoplasty effectiveness kind of questionnaire that we use very commonly in ENT. And it basically says, how well can you breathe through your nose? And so that was significantly reduced, and nasal floor width was improved. And then they did a similar kind of follow-up study to the one that they looked at with kids, where they looked at kind of the impact on the nasal valve, and they found, about a 2.5-degree increase, similar to the pediatric population, which is pretty substantial, and that potentially also likely contributed to why patients can breathe so much better. So, transitioning into kind of how I now am doing the surgically assisted maxillary expansion. When I was at my fellowship with Dr. Dady at Penn, we were, doing the dome, but, in our hands, we're not, seeing necessarily replicatable results. And obviously we had a lot less experience than Dr. Liu. And so we kind of ended up creating or pioneering this kind of hybrid approach between dome and ease, where we're kind of cutting the entire mid-palatal suture from front to back. And so over the last, 4 years that I've been in practice now, it's constantly kind of evolving and improving to be, more and more minimally invasive. And so I typically use, all virtual surgical planning for these cases, where we can use a little cutting guide here to ensure that we're making a cut between the central incisors to not damage tooth roots. We typically will make 3 small incisions. There's a little incision kind of underneath the upper lip here, where we can cut the anterior nasal spine kind of right down the middle here. There's a little incision laterally where we can just cut a small wedge of the lateral buttress. We'll separate the pterygoid plates, which are kind of in the back of the maxilla. And then I'll come back to that in a sec. And then we also look at bone density mapping. This is something that we're studying to see, are there certain patients where we can limit the type of cuts we're doing? So maybe in some patients, they only need the mid-palatal suture cut. Maybe some patients need every single suture cut in order to fully expand. But this is kind of the initial concept of the 2-pen. And so this is looking at the left nasal cavity. And basically what we do is through that intraoral incision, we can actually lift the entire floor of the nasal cavity up. So we basically go to what's called the piriform rims, we lift it up, and you can actually lift the septum off of the maxillary crest. And so we're looking with an endoscope. So we have a little ENT camera, which we use frequently for nasal surgery cases. And all of this right here is the floor of the nasal cavity mucosa. So basically we've lifted everything up like a carpet or a rug, and we've separated the septum off the maxillary crest here, which is right in the midpoint. And then we'll take a piezo saw and essentially run from the anterior nasal spine all the way to the posterior nasal spine to fully separate the mid-palatal suture. And so this is kind of a, pre-expansion, post-expansion. This was a case initially that was published working with Dr. Evans in Philadelphia. And so for our first, publication that had come out a couple of years ago now, we looked at, how is this impacting nasal cavity width? And so the posterior nasal spine expanded about 3.5 millimeters. The intermolar distance on average between the first molars expanded by about 6 millimeters. And this was done typically with either an MSC or a custom MARPE. Interestingly, the palatal height dropped a little bit, so it became slightly less narrow arched as everything widened. The piriforms expanded by about 2 millimeters, and then the anterior nasal spine was about 7 millimeters. And so this was just, an interesting case, and I think it really lends credence to kind of looking at this global picture of kind of nasal obstruction. So this was a 25-year-old gentleman. He had a 4-year history of mild to moderate sleep apnea, just could not tolerate, CPAP, tried really hard, was really dedicated to trying to improve things, persistently sleepy, felt like his, nose was obstructed. He had a septoplasty in 2018 for nasal obstruction. He underwent an MMA for his sleep apnea in 2020 by an outside surgeon. He was still having residual mild sleep apnea, persistent nasal obstruction, daytime sleepiness. He had trialed everything from an oral appliance to a tongue retaining device. And he just kept feeling like his tongue was still too large for his mouth. On exam, his septum was straight. His turbinates were reduced. He didn't have very obvious skeletal deficiencies on exam, essentially a class 1 occlusion. And after looking through his sleep study, because as sleep medicine physicians, we would look through that sleep study in detail, there was still some concern for essentially nasal obstruction versus tongue-related obstruction, causing persistent re-res or respiratory effort-related arousals and kind of this sleep disturbance. And so interestingly, this was a big guy. He was like 6'5". His maxillary width was 31.5 millimeters, which for most people is pretty reasonable, but he still has like almost a mild crossbite. His teeth are still a little bit tipped in. And you just felt, again, that there was just not enough space. This is a sleep endoscopy that we did on him. So, a lot of these patients will work up with what's called a drug-induced sleep endoscopy, where we give them propofol through the IV, look with a camera. I know it's kind of a hot topic, both within ENT and outside, but I still find it, very useful in my patients. And so this look, we're looking through the nose. Here are the adenoids in the back of the nose. This is his soft palate, just for reference. This is right, this is left. So he's having kind of front to back, a little bit of soft palate collapse, but nothing significant. But when we look lower down, this is the tongue. And his tongue is just completely fallen back and blocking his airway. And so as soon as he goes to sleep, there's essentially 100% base of tongue collapse on this patient's exam. And so again, now, as orthodontics has evolved, this was a couple-year-old case. We're trying to avoid, the Mack truck that can be driven through the diastema there, but he had really significant expansion. and essentially complete resolution of his symptoms. So he had gone through all these things, but essentially the maxilla was still too narrow for, what he needed physiologically. And after expansion, nasal breathing, nasal obstruction resolved, felt like he had enough space in his mouth, and basically had resolution of symptoms. This is just another example of a case that I did. Again, this was a surgically assisted palate expansion, just kind of looking through the progression as the patient is turning. And you can see a pretty nice parallel kind of expansion here from front to back. Again, here is kind of pre-op and 6 weeks post-op, and then orthodontically, he's going to start walking the teeth back together here. So, why does this matter? And in particular in the ENT world, so this is another publication from Dr. Liu and his team. So they had looked at 32 patients that had persistent nasal obstruction post-septoplasty. They had a narrow palate. And again, to go along with the theme of this talk, they underwent a dome procedure and had, significant resolution of their nasal obstruction. Their upward sleepiness went down and had a lot of improvement. And so, something that we need to keep in mind is, especially as in ENTs, and this is what I try to, every talk I give to my colleagues in the ENT field, that when we're looking and evaluating patients for nasal obstruction, that we can't just look in the nose. We need to look at the entire craniofacial structure, look in the mouth, see what their palate looks like. So just kind of towards the end here now, I just want to touch on non-surgical maxillary expansion because, in the ideal world, no one would need surgery. And as much as it pains me to say that as a surgeon, and I enjoy doing these surgeries, it would be great if everyone could expand non-surgically. Unfortunately, that, is not always the case. But this is one case. So 34-year-old male, no significant past medical history, some intermittent snoring, unrefreshing sleep, nasal obstruction. Home sleep study testing was largely negative. There was no in-lab PSG. On exam, his septum was straight, no significant turbinate hypertrophy, no significant nasal valve collapse, environmental allergies, had tried intranasal steroids like Flonase without improvement. And the nose score was 60, which again, that nose score goes from 0 to 100. We think, over 40 is pretty, clinically significant nasal obstruction. And he underwent MARPE. And, again, I'll kind of touch on this at the end, but it's still a little bit hit or miss with, adult males over the age of 30, but this was a custom MARPE. And you can see this is in the very back of the maxilla. This is the posterior nasal spine that essentially split right down the middle. And you can see this really nice parallel separation of the maxilla front to back with that MARPE. And, significantly looking at the pre and post expansion, you can see that the piriform width, kind of the very front of the nose, expanded over 4 millimeters. The nasal floor width at the first molar went, expanded about 4 millimeters. And then the molar width or intraoral volume expanded by 8 millimeters. So really significant improvements. And this is my own case, actually. So I know Renata has seen this picture. But this was kind of my own journey. I specialize in this area, and I felt like at some point I needed to walk the walk that I was talking the talk with my patients. And so I worked with a very close colleague of mine, Yi-Wei Huang, who's a great orthodontist in Chicago, that has a lot of experience with MARPE and had very significant improvement. And fortunately, I was already married and had kids, and my wife tolerated my gap for a couple months as things were closing. So again, I think this is it's so fascinating, having gone through this myself now to see kind of, I had flaring of the molars to be able to fit properly, pretty narrow palate. My teeth looked straight. I had multiple, I had rounds of orthodontics as a kid. I had Invisalign again as an adult, but just a much broader arch. And interestingly, I mean, you can see these things that we call negative corridors where, now that you see it, you can never unsee it. So every patient that comes in, I have them smile and show me their teeth, and you can see right off the bat, oh, this person has a narrow palate versus someone, post-expansion now where the teeth essentially fill up the entire smile. And you can see it's kind of a much broader smile. So cosmetically, I think it looks better, but most importantly, nasal breathing has vastly improved. The big things with non-surgical expansion, we still lack a lot of the literature that we need in the adult population. So there are a lot of very incredible orthodontists around the country, Yi-Wei Huang in Chicago, Mariana Evans, Audrey Yoon, that are, doing some pretty amazing stuff with these palate expanders. But we still need more data that can be published, that can be rigorously studied. So anecdotally, from talking to, my orthodontic colleagues, it seems like in general, the mid-palatal suture in women does not fuse as significantly in men. And so women of all ages seem to be having much higher success rates. But I think, even in men over the age of 30, I'm seeing 60 to 70% success rates. I've heard people quote, much higher than that, but I want to see the numbers. I want to actually see data and not just kind of anecdotal evidence. So, the hope is that at some point, with the way the field is evolving, that we can get to a point where these non-surgical expanders do my job for me. And that would be, great, but also sad because I love the surgeries, but I think we still have a little bit of a ways to go. And so in these 30 to 40% of patients, my job is figuring out how can we minimally invasively as possible, kind of separate the sutures and allow them to have as non-surgical an expansion as they can. All right. So appreciate all those out there listening or that will be listening in the future here. So, just as a summary here, our craniofacial skeletons are changing. I think it's a really fascinating, topic. I think we still need a lot more studying of this topic in particular. And are there things that we can be doing for our children? We think, okay, can we expand earlier and earlier? And does that make a difference? And the answer is we don't know. So, I put my 4-year-old daughter in a palate expander because I saw she was already nasal breathing and having this, but we don't have any data to say, is that actually going to change the long-term outcome? Is she going to still develop a narrow palate? I've seen plenty of patients that were expanded as, 8 to 10-year-old kids. They're still retrognathic. They ended up, it doesn't change the growth trajectory. It just expands them and they're still narrow as adults. So there's so much that we need to figure out. And, there's form, there's function, there's all these different things that if you just expand the maxilla without converting them to a nasal breather or changing, we think tongue position, all these things that we're going to have incomplete outcomes. And, same with, addressing these skeletal deficiencies early in kids. Can we prevent, adults from developing sleep apnea down the road in some of these people that, it's more skeletally, structurally based if we fix them as kids. And then the important thing, again, to harp on that I talk to all my colleagues about is, and it's interesting because now I've given enough talks in my own department where now a bunch of my rhinology colleagues, my sinus specialists, are seeing patients and referring them in to say, hey, this guy's got a really narrow piriform or they have a really narrow arch palate. We need to incorporate, they still need X, Y, or Z surgery, but we should probably incorporate something with expansion in there. And so it just needs to be something to keep in mind. It's not a one size fits all. Not everybody needs to be expanded, and not everyone's going to be improved by expanding them. But I think it's really a fascinating area that has helped a lot of people.
Wow.
Sorry for the whirlwind there.
That not at all. That was incredible. Oh my gosh. It is such a different perspective coming from you. I absolutely love doing these webinars because every single person that comes, every single professional that comes talk to us brings something so fresh to the table. So thank you so much for spending an hour with us today. We do have some questions.
Yeah, please.
Time. Okay. Well, Mrs. Carstensen said she's 63 years old and she just finished her MARPE treatment. She is in orthodontics now for 12 more months and she's using Dr. Rebecca Buckle. We both met, where were we? In Orlando, and we both had our diastemas. Yes, it is extremely difficult to date with spaces all over your teeth, especially whenever in the dental field.
Yeah, right.
People will look at me like, aren't you a hygienist? Like, why don't you fix that?
Yeah, right. Yeah, I had some friends early on that, I had like an 8mm gap in my teeth. I had my neighbor who's 4 across the street was like, you lost a tooth. So she was so excited for me that the tooth fairy was going to come visit me because I had a tooth-sized gap in my front teeth.
This is awesome. We just came back from Australia and Dr. Claudia Pinter and there was another orthodontist there. He's going to come speak for us. They're actually also are doing some incredible work with expansion and with TADs, and they're using TADs differently. But Dr. Claudia was showing a lot of cases where they move a lot slower and then you don't have gap, because
Sure.
the biggest complaint for adults is, I don't want to have that huge gap in my face. I didn't care. I was out there talking and still
Yep.
recording. I made so many videos, and now I look back and I was like, oh my gosh. But people would look
I
at me and say, how are you so confident? And I was like, I can't see it. You can see
Yeah,
it.
I would call it, I was when I would see my Penn colleagues and all my former fellows with Raj, I would call it gap envy, that they were jealous
Yes.
of my gap.
Yes. The
But
estimates are sexy.
yeah,
Let's change the
I
paradigm.
mean, it
Breathing through
is
your
interesting.
nose.
There's some like I've worked with Rick Robley, who's a really great orthodontist down in Arkansas, and he, a couple of the surgical cases I've done with him, he uses Invisalign trays and basically maintains the gap at only, a millimeter the entire way, and does some pretty amazing stuff. So I think it's shifting more and more to how can we find this bridge of like, obviously this is for nasal breathing and for, sleep and all these things, but obviously we have to keep in mind the cosmetic nature and, doing things. So there are a couple I saw one
Yes.
question, how do you determine when to enlarge the room or rearrange the furniture first? That is a really good question. I think a lot of times it depends on the patient. And so some patients are, very much, I don't want to go through 12 months of, expansion. I don't want to have braces. I don't want to have all these things. The other factor that is a very real factor is that this is not cheap. It's not covered by insurance. And I see, I'm at a big academic center. A lot of my patients that I see are Medicaid or underinsured patients. So many people that need this can't afford it. And so the
Mhm.
cost becomes a big issue for a lot of these patients. But really it comes down to, some people say, okay, well, maybe we do a stepwise approach. So, you have a deviated septum, you have allergies, let's treat you medically. Maybe we fix your septum, let's see how much you improve. And in some patients that improves them enough where they say, okay, let's stop there. Other people would say, and if they're not fully improved, next step, we go to expansion. Some people say, okay, well, if I can expand non-surgically, let me see how well that works first. I know I have a deviated septum, but if the room's bigger, doesn't matter if the furniture is disheveled. And we see how that goes, and we can always do a second stage nasal surgery. So it's a conversation with every patient. And I guide it to what they're looking for and what their, kind of risk profile is.
Perfect. Another question from Anne is 2-pen the only surgical maxillary expansion procedure that results in lowering the palatal height?
That is a great question. I don't think we know the answer to that. I think we don't have enough data from Dome, from Ease, from all these things where we've kind of critically looked at that. So I would not go out and tout that, I'm the only person that can do that. So we don't have a good answer to that.
However, I will share that Dr. Lipkin recently sent me a before and after of my CBCT, and you can see also palatal height
That's
a little
increased.
bit lowered with the
Yeah.
MARPE. I will
Yeah.
show you, Anne. Can you explain the significance of the piriform sinuses and posterior nasal spine in the nose? How do they contribute to nasal obstruction?
Yeah, good question. So the piriform is the front door of the nose. So the piriform is basically the bones when you feel on the side here. The width of that is how wide the entrance to the nasal cavity is. And so if that is widened, the room widens, and the posterior nasal spine is important because that is just the back of the nose. And so if that widens, it means the entire back walls of the nose have widened. So it means that it's a front to back widening rather than kind of like a V shape. So, the front door is wide open, but the back door is closed. And so you're not going to have potentially the same amount of improvement in nasal breathing if you don't get this kind of parallel expansion of the nasal cavity.
Oh my goodness. Tell me a little bit in terms of sleep surgery, patients that are asymmetrical. Are there things that you can do with the pens, with these procedures, the 2 pens to fix some asymmetries?
Are you saying asymmetry is in like they have a crossbite on one side and not the other? Or like I have one patient where like palatal height is lower on one side versus the other?
Just we see so many skeletal asymmetries, and usually expansion makes it a little bit worse. I'm not sure. Sometimes when they have MMA surgery, there's a few things that the surgeons can do to correct some asymmetries. Of course, you won't correct the eye asymmetry.
Sure.
Um,
Yeah, that's a good question. That in all honesty, I don't have a ton of experience with. In theory, you could try things like, if they're asymmetric on one side, do you only cut, the lateral buttress and the pterygoid plates on one side and leave them intact on the other, so that as things expand, you get more expansion on one side. I haven't done that in practice. And I think, even with MARPs, I've seen it non-surgically with surgical expansion, you can get asymmetry because, again, our bones are not meant to be split as adults. And so we can't always perfectly control the vector, the forces that we're doing. So I think without a more invasive MMA, it's a lot more challenging. And maybe there are other surgeons out there that can do it, but I would be very cautious with a MARP or surgical expansion without something like a full SARP where they, cut the jaw and move one side to a different place than the other.
Okay, perfect.
Question though.
Somebody, I had another question. Somebody said, I took a CE given by an airway-focused orthodontist, and he said that when the maxillary suture separates, cartilage fills in, not bone. Is this true?
I am not familiar with that. So typically, no, physiologically, that wouldn't make sense. When bone separates, it should fill in with new bone. When we're seeing on the post-op scans, we're seeing bone filled in there. So I'm not familiar. I would have to look into that more, but my understanding and from what I've seen in my own experience is that when bone is broken, it's the only actually cell in the body that will heal to bone. So it's not, bone heals to bone on MMA, on all these things where, you tear your ACL, it's going to cause scar tissue or some other kind of thing, but it should heal to new bone.
I love that. How often do you do DISE? What is the protocol to request one? How easy are insurance companies to pay for a DISE procedure? And last question on the DISE, what is the experience for the patient?
Yeah, so in general, anybody that has snoring or sleep apnea, we've been pretty good about getting insurance to cover it. Sleep apnea, 100%. Snoring is a little bit, sometimes we need to fight a little bit with insurance. The DISE is, I try to do them on essentially every single patient. I think it's just one other piece of information that it can give me. I know, again, there's a lot of people that say, okay, it's propofol, it's not real sleep. Depending on how fast you give propofol, you can get different collapse patterns. It's not, they're on their back versus their side. Everybody has their own opinions about it. I think it's useful in my own practice. So, it's pretty simple. You basically show up, it's in the operating room in my practice, at least. You show up about an hour ahead of time. You come in, we bring you to the operating room. I do it a little bit differently. So I do something called DISE PAP, which was first described by Raj Dadia, where I'll actually put a little nasal CPAP mask on the patient's nose. We give them propofol, we put them to sleep, and then I'll look through the mask, through the nose at the back of the throat to see what their collapse pattern is. And then once they're kind of, sedated enough where they start snoring and having apneas, we see what's kind of collapsing. And then we'll actually slowly increase the CPAP pressure from 4 to 20 centimeters to see what is the overall collapsibility of the airway. So does this patient only need 4 centimeters to open and kind of stabilize their sleep apnea? Do they need 20 centimeters? What it means, we're still actively studying. So we have, a database of almost 500 patients now that we're studying, that we've gone through this DISE PAP to see, does this help predict outcomes or improve our selection for different sleep surgeries? But basically after 20 minutes, you just need to ride home. You stay for about 30 minutes afterwards. You can eat and drink what you like. You're just a little bit tired, maybe the rest of the day, but it's a pretty minimally invasive option.
Perfect. So for these DISE patients, usually to be accepted by insurance to have this procedure done, can an at-home sleep study be sufficient for an insurance company? Do they request a lab?
No, I do home sleep studies on a lot of patients, and I'll get updated home sleep studies, if needed. In certain patients, before I do a surgery, I want an in-lab sleep study. So patients that have different cardiovascular health issues, like we want to make sure there's no central sleep apnea. There's not a different type of sleep apnea. So in select patients, I think it's helpful to get an in-lab sleep study, but in general, home sleep studies are fine. Perfect.
And last question, from your experience, looking at in-lab and at-home sleep studies, is there a huge difference on the information that we do get from the home sleep study?
Very dependent on the patient. So, interestingly, I think the people that are UARS type picture, I think a lot of times, or a lot of their issues are arousal based. And what I mean by that is that they're breathing, maybe their oxygen, they're not breathing as much as they should be. Their airway's a little bit restricted. It's not enough to cause their oxygen level to drop by 3 or 4%, but it causes this micro arousal during sleep where they're breathing and they kind of have a little wake up. It rouses them out of REM or N3. They go back. Home sleep studies aren't as good. Even watch PATs are not as good as taking that, where an in-lab sleep study is going to know, okay, this person had, 30% decrease in breathing. It led to an arousal. We're going to call that one event. So, in young, healthy people, typically, even though the in-labs are like not pleasant, they're obviously not super representative of normal night of sleep, but they, I think, are in young, healthy people. Home sleep studies can often miss some of the issues.
That is incredible to hear from you. Thank you so much. This has been such a wonderful hour. I do just have a quick announcement for all of our Area Circle members. First of all, we can bring this live on Thursdays because people choose to be members. So thank you so much for supporting what we're doing on Area Circle. We have the Beauty of Breathing podcast. If you guys are not following that yet, please click follow, share your review with us. And I think that's all we have besides the directory. If you're not in the directory yet, please join us. It is free right now to join the directory. You go on airwaycircle.com, click on directory, scroll down and click on add entry. You put all of your information there, including your email, your phone number, and the patients can directly message you to request an appointment. So thank you, Anne, for always having such incredible questions also. And yes, we are AC. Thank you, everybody. Have a wonderful day, Dr. Michael.
Thanks, Renata. Thanks for having me. Appreciate everyone tuning in. Have a great weekend.
Fabulous.